Omnifit Scleral Tuck Lens, a novel design. It is a major breakthrough in surgical implantation of scleral fixated intraocular lens. We hereby present a case of a 27-year-old male with ectopia lentis. At presentation, the BCVA was finger counting close to face. The primary surgery performed was lensectomy plus vitrectomy. This newly designed scleral tuck lens is inserted through the primary wound. Two scleral pockets of 20 gauge at 3 and 9 o'clock are created to pull the tucks out through the scleral pockets. The final BCVA of this patient was 618. Here we present another case of an 8-year-old female presenting with poor vision, ectopia lentis and clinical features of Marfan syndrome. Primary surgery of lensectomy plus vitrectomy was performed. Two scleral pockets are created at 3 and 9 o'clock with MVR and with the help of a crescent blade. This design is a self-sustaining, cost-effective and easy to implant foldable lens. The lens is inserted with an injector through a clear corneal phacotunnel. Then the lens is adjusted and the flippers of the lens are pulled out with the help of forceps. It is a self-sustaining lens because it does not require any non-reusable glue or suture material to fix the lens. And because of this, the lens is very cost-effective. The final BCVA at the end of 2 months of this child was 6.6. Here we present another case of a 10-year-old male presenting with globe rupture and traumatic cataract with primary capsular rupture after primary surgery of wound and vitrectomy. This lens design has 4 parts: the flipper, neck, the haptics and the optic. The flipper has an eyelet in case of doubtful sclerotomy fixation. The flipper is held with the forceps and pulled out through the sclerotomy ports of 20 gauge each. The optic of this lens is large enough to cover even a mesopic pupil. The haptics have a 4-point fixation, so minimal pseudophycodonesis is expected. The flipper is rigid to stay in position for longer period. The learning curve is less and it is less time consuming. Hence, corneal damage is lesser and the patient gives better post-operative outcomes. The best corrected visual acuity at the end of 1 month of this patient was 680. Here we present another case of an 8-year-old male presenting with closed globe contusion. Clinically, the lens was dislocated with no PL vision and iridodialysis. A crescent blade is used to create the scleral pockets. An MVR is used to enter through the scleral pockets of 20 gauge. The lens is inserted through the primary wound at 12 o'clock. An AC maintainer is used to maintain the volume of the eye. The flipper is then pulled through the sclerotomy port with the help of forceps. And the lens is tucked at 3 and 9 o'clock without any help of suture or glue. The final best corrected visual acuity of this patient was 624. Here we present another case where there is loss of capsular support and the intraocular lens is hanging in the anterior chamber as well as the posterior chamber. A crescent is used to create the scleral pockets and the forceps are used to pull out the intraocular lens inside. Primary vitrectomy has been performed and the scleral tuck lens is inserted through the primary wound. As the the capsular support has been lost, the scleral tuck lens is tucked through the 3 and 9 o'clock position of sclerotomies, and the conjunctiva is sutured back. The final best corrected visual acuity was 680. A 7-year-old female presented to the OPD with a history of wooden stick injury. Clinically, the picture was of endophthalmitis. The patient presented with vision of no pain. She was given primary intravitreal injections of antibiotics. Then, vitrectomy of endophthalmitis was performed. After a few months, scleral tuck intraocular lens implantation was planned. The lens is inserted through a clear corneal phaco tunnel with the help of an injector. Hence, this design is fit for use in pediatric patients with ectopia lentis, Marfan syndrome, microspherophakia. It is used in cases of trauma with primary anterior capsular rupture, closed globe contusion with zonular rupture, nucleus drop post-trauma, iatrogenic with back delivery or rent with loss of capsular support or endophthalmitis. This breakthrough design is in surgical implantation of scleral fixated intraocular lens is a reliable and effective fit with good stability and minimal induced astigmatism in difficult situations. Post-op best corrected visual acuity after 1 month was 612. Thank you for your patient listening.